Bismillah ar-Rahman ar-Rahim. Today we are going to discuss acute appendicitis, which is a very common disease that you will confront in the reception room and in the emergency room. The objectives of this lecture is to review the pathophysiology and clinical presentation of acute appendicitis, to understand which patient groups at height risk of misdiagnosis, and to discuss the use of laboratory and imaging studies in the diagnosis of acute appendicitis, and at last to outline the treatment plans. If we are going to discuss the epidemiology, it will be evident that acute appendicitis affects 6 to 7% of the population. The peak incidence is in adolescents and young adults with a slight male predominance in this age group. Then you have to understand that infants, elderly patients, pregnant women, and immunocompromised patients, these are 4 groups, tend to have atypical presentation and have a higher morbidity and mortality. This is to show the anatomy of the acute appendix, of the appendicular appendage. The appendage, it is located at the termination of the small gut and at the beginning of the large gut near the cecum, and it is taking blood supply as arterial blood supply from the termination of the ileocolic artery with an artery known as the the appendicular artery running in the mesoappendix. Now we come to the pathophysiology. The process starts with obstruction of the lumen of the appendage. This obstruction is most commonly is due to secondary to a feculis in adults, and in children the obstruction occurs because of lymphoid hyperplasia. Now, after obstruction, there is continued mucosal secretion. This worsens the edema, high luminal pressure, and bacterial proliferation. Transmural necrosis and bacterial penetration then occurs. Initial luminal distension triggers visceral afferent pain fibers which enter at the 10th thoracic vertebral level. This pain is generally vague and poorly localized. Pain is typically felt in the periumbilical or epigastric area. As inflammation continues, the serosa and the adjacent structures become inflamed. This triggers somatic pain fibers innervating the peritoneal structures, typically causing pain in the right iliac fossa. The change in stimulation from visceral to somatic pain fibers explains the classic migration of pain from the periumbilical area to the right iliac fossa seen in acute appendicitis. Exceptions exist in the classic presentation due to anatomic variability of the appendix. Appendix can be situated retrocecal, causing pain to localize to the right flank. In pregnancy, the appendix can be shifted and the patient can present with right upper quadrant pain. This illustration shows that the retrocecal position and the pelvic position constitute most of the positions of the appendix in humans. So the presentation usually comes from these 2 common situations. In some males, retroalar appendicitis can irritate the ureter and cause testicular pain. Pelvic appendix may irritate the bladder or rectum, causing suprapubic pain or pain with urination or feeling the need to defecate. Multiple anatomic variations explains the difficulty in diagnosing acute appendicitis. As for clinical presentation, classical presentation occurs in only 50% of the patients. Pain begins in the periumbilical or epigastric region due to appendicular distension, and this is a referred pain. And then pain localized to the right iliac fossa as parietal peritoneum is irritated in the area by infection. Anorexia and nausea occur almost uniformly after the pain, and this is a very important symptom. Physical examination findings depend on the duration of the illness prior to the examination. Early on, patients may not have localized tenderness. With progression of the disease, there is tenderness to deep palpation over the McBurney point. This is the McBurney point as seen in the illustration. It is 1/3 lateral to a line joining the anterior superior spine to the umbilicus. Physical examination of the patient with acute appendicitis may show mild fever. This is usually not exceeding 38. McBurney's point tenderness, and there is a very important sign known as Rovsing sign. This is when you press on the left iliac fossa, the patient feels the pain in the right iliac fossa. Psoas sign and obturator sign. The psoas sign is the irritation of the psoas major with flexion of the hip. Trying to extend the hip elicits exaggeration of the pain. PR or rectal examination may show some tenderness at the tip of the examining finger if the appendix is touching the rectum. This is again the McBurney's point. The tip of the appendix can lie almost anywhere in the abdomen. As you see in the illustrations, the cecum can be high, we call it subhepatic. And if there is malrotation, you can find the cecum in the left hypochondrium. The cecum can be shifted down in the pelvis. The cecum usually lies in the right iliac fossa. That's why the McBurney's point tenderness is a very important sign. Additional components that may be helpful in diagnosis, what we call rebound tenderness. This means that when you remove your hand suddenly over the tender area, the pain exaggerates and the patient feels a glimpsing pain. There is usually voluntary guarding of the muscles, and this can be exaggerated to be described as muscular rigidity. And tenderness on rectal examination at the tip of the examining finger. Psoas sign is, to elicit the psoas sign is to place the patient in the left lateral decubitus, and then you extend the leg at the hip. If there is pain with this movement, then the sign is positive, and this means irritation of the psoas major muscle. The obturator internus sign is when you passively flex the right hip and the knee and internally rotate the hip, there is pain, exaggerated pain, and this means that the appendix is touching the obturator internus. Fever, another late finding. At the onset of the pain, fever is usually not found. Temperature more than 39 C are uncommon in the first 24 hours, but not uncommon after rupture. Diagnosis of acute appendicitis should be suspected in anyone with epigastric or periumbilical right flank or right-sided abdominal pain who has not been operated upon for appendectomy. Women of childbearing age need a pelvic examination, this is PV, and a pregnancy test, because ectopic pregnancy and the intact pregnancy with some pain in the uterus simulates very much acute appendicitis. Additional studies like CBC and urinary analysis, and then we resort to imaging studies. CBC, the YBCs is of limited value. However, you usually find the leukocytosis and shift to the left. Sensitivity of an elevated YBCs is 70 to 90%, but specificity is very low. A CRP and ESR have been studied with mixed results, so you don't have to depend on them. Urine analysis. Abnormal urine analysis results are found in almost 20% of the cases. Abnormalities include pyuria, hematuria, bacteriuria. Presence of more than 20 YBCs per field should increase consideration of urinary tract pathology, not acute appendicitis. Also, the presence of RBCs usually indicates a urinary tract problem, not acute appendicitis. Imaging studies include X-ray, which is useless now. We use the ultrasound and CT instead. So we don't depend on abdominal plane X-rays now. The ultrasound as an imaging technique is very important, especially in children and in women at the childbearing period, because CT can be injurious to these two types of patients due to exposure, increased exposure to X-ray. So ultrasound is very important. The signs in the ultrasound: graded compression, reported sensitivity of 95% and specificity of almost 90%. If you press with the probe of the ultrasound and you find non-compressible distended appendix. Basis of this technique is that normal bowel and appendix can be compressed, whereas an inflamed appendix cannot be compressed because of the high pressure, as we explained, due to the obstruction that started in the lumen. Non-compressible, more than 60 millimeter appendix, or the presence of appendicolith, a feculith, a periappendicular fluid or abscess are sure signs in ultrasonographic examination. This indicates an ultrasound showing, an ultrasound at the right iliac fossa showing as if it is a cross-section, a circularly distended appendix, and if you compress here with the probe, there will be no compression of the lumen. This indicates, and also there is some water here around, fluid that could be pus or only exudate. These are all sure signs in ultrasound examination of the appendix. Limitation of ultrasound is present, especially in retrocecal appendix, because it is, the appendix here is covered with cecum full of air, and this impairs the sensitivity and the specificity of using the ultrasound for diagnosis. Also, if there is perforation of the appendix, you can compress and you see the appendix compressible. So the perforation here makes the appendix compressible by the ultrasound probe, and this may, for those who are not perfectly using the ultrasound, may indicate that this could be a normal appendix, and you can miss. Now we come for the CT. CT is the best choice based on availability and alternative diagnosis. Here I would like to say that CT with IV contrast is the most important diagnostic tool used in acute abdomen in general and in acute appendicitis. Even if the appendix is not visualized, diagnosis can be made with localized fat stranding in the right iliac fossa. There is controversy about the usage of oral or enema water soluble contrast. This is not necessary to be used. You can use only IV contrast without any oral or enema contrast. Water enema or oral water can be used, but this consumes precious time. So usually we take the patient from the ultrasound room to the CT room without any oral water or contrast, or enema water or contrast, with IV contrast only. Enhanced CT diagnosis in acute appendicitis necessitates IV contrast even without gut contrast. The usual findings of acute appendicitis is as follows: hazy appendicular densities and feculi, enlarged appendix more than 6 millimeters, increased enhancement of the appendicular walls in phlegmon, increased enhancement of the periappendicular gut walls in the phlegmon. Phlegmon means inflammatory process joining organs together without the presence of pus. Deficiency of appendicular wall means a gangrenous appendix. Periappendicular fat stranding retrocecal appendix, the presence of free fluid or abscess cavities with air due to the gas-producing organisms or due to perforation of the appendix. Is there a need for contrast? Yes. The answer is yes. Although in 90% of cases you get, in cases without contrast, you get 90% sensitivity to diagnose acute appendicitis, yet if you use IV contrast, this sensitivity jumps almost to 100%. So IV contrast is important. If you can do it, you can only abstain from using IV contrast if the serum creatinine is high. CT appears to change the management decisions and decreases unnecessary appendectomies in women, but it is not as useful for changing management in men. It is very important to use or to keep in mind that the CT is the final method for imaging the acute appendicitis. Again, possible findings in acute appendicitis: enlarged distended appendix, appendicular wall thickening, periappendicular fat stranding, focal cecal apical thickening, appendicolith or feculith, target structures, concentric thickening of the inflamed appendicular wall, extraluminal air means perforation. Most useful CT scans findings of the diagnosis of acute appendicitis. This is an example of an enlarged, thickened wall, enhanced wall of acute appendicitis in CT. This is another example of distended, thickened wall with enhancement in CT with stranding of the fat. You see the fat here is clear. Here you find fine white lines or white areas, and that's what we call stranding of the fat, and this is due to edema. This is a very important, very illustrative fat stranding sign with enhanced, enlarged, thickened wall of the appendix. Again, thickened wall, appendicular wall thickened and enhanced with stranding of the fat around. This is a feculith, appendiculith, In the CT, it appears as a stone like this, with stranding of the fat. This is a picture of what we call a target structure. This means a concentric thickening of the inflamed appendicular wall. If you find air outside the lumen, like here and here, this means that there has been perforation or gas-producing organism. This is a case of a 19-year-old female with thickened wall of the appendix with lymph nodes in its mesentery and stranding of the fat. This is a classical fecalis sign. Here we have loss of part of the wall of the appendix, and this means gangrene. Of course, you will find air outside the lumen. A typical case of enhanced wall with compression of the lumen. Here the appendix is inflamed, thickened wall with fat stranding and with air also extravasated from the lumen. In CT, it's very important that you can find pus collections or abscess cavities, and this is a complicated appendix. It's not an acute appendicitis anymore. It is a complicated appendix with perforation and pus formation. This is a presentation of a case of dilated appendix, also here. This is a classical case of fecalis, here also. In retrocecal appendicitis, CT is very important for diagnosis, like here and here, because the ultrasound here is incapacitated by the presence of air in the overlying cecum. This is a case of perforated appendix, complicated appendix with phlegmon formation. Phlegmons means inflamed tissues gathered around the inflamed appendix. This is a case of abscess cavity here with a fecalis. This patient was given a contrast in his gastrographine contrast in his colon. This is not necessary to be used, as I said. It's only for CT with IV contrast to be used. Another case of abscess cavity. Stone ureter can be diagnosed with a normal appendix, normal dilated appendix, but the stone ureter. So it's CT is very important in differential diagnosis of acute appendicitis. One of the most important differential diagnosis of acute appendicitis is right ureteric stone. So it can be diagnosed by CT. CT in acute appendicitis is also perforated retroperitoneal appendix causing retroperitoneal abscess by gas, producing organism, the usual situation. This technique It requires flank incision, not laparotomy, to drain the abscess. Special populations. As I said, there is a typical patient who is young adult, and there is an atypical populations for acute appendicitis, and these are 4 types of patients: very young or very old, so we are talking about children, pediatric, or elderly patients above 65, pregnant women, or patients with immunocompromised status, like patients with HIV or patients using chemotherapy. High index of suspicion is needed in these groups to get an acute, accurate, rapid diagnosis, because in these patients the clinical picture is not typical and you can miss, and the time is very precious. They early perforate, they early complicate, so if you don't interfere early, you can lose your patient. In the very young, diagnosis may be more difficult to establish. YBCs is likely to be normal. 12% of the cases show normal YBCs. Children are more likely to progress to perforated appendix. This is usually due to underdevelopment of the greater omentum. Perforation of appendix in pediatric age, in less than 2 years, perforation approaches 100%. From 3 to 5 years, perforation is around 70%. From 6 to 10 years, perforation is around 40%. In the very old patients above 65 or 70, greater morbidity and mortality occurs. There is less typical presentation. Cancer may be a possibility as the underlying cause. Perforation of more 50% perforation, if it occurs, more than 50% of the patients die, so you have a very high mortality and you have also a very high morbidity. In the third group, who is pregnancy with acute appendicitis, clinical findings and laboratory investigations and surgery are all changed. It occurs in for 2,000 pregnancies, more common in the first 2 trimesters. The appendix is pushed superiorly and laterally. The YBCs normally is above 15,000, so the YBC sign here is not valid. Premature labor can occur in 10 to 15% with surgery. Perforated appendix leads to fetal death in 20%. Rapid diagnosis and treatment is advised. In pregnancy with suspicious acute appendicitis, you will use for imaging the ultrasound first. But if the ultrasound is not conclusive, here you cannot use the CT. Here, the only situation where you are obliged to use magnetic resonance studies. In AIDS patients, beware of the other viruses, Kaposi sarcoma or underlying cause. YBCs may not rise because these patients are poorly reacting to inflammation. So now we have to classify patients into 2 types: non-high-risk patients and high-risk patients. The high-risk patients are children, women in childbearing age, elderly patients, immunocompromised patients. These 4 groups should never be forgotten. Now we have situations. A situation with sure clinical diagnosis with CBC showing leukocytosis and urine analysis show no indication of any urinary tract problem. A situation of non-definite diagnosis, including CBC and urine analysis. A situation where there is a possibility of complication like perforation with localized abscess or general peritonitis and phlegmon formation, and this is usually a presentation more than 72 hours starting from the start of feeling pain. In non-high-risk patients, what we do, if you have a definite diagnosis with CBC and urine analysis, and this occurs in 50% of the patients, you proceed to appendectomy without any other investigation. But if you have no definite diagnosis, you admit the patient to the ward and re-examine after 4 to 6 hours. This re-examination, you have to go then in one of two pathways, or one of three pathways. If the clinical picture confirms and becomes classical, you proceed to appendectomy. If the clinical picture resolves and patient become normal, you discharge for next day examination. If still he is not definite in diagnosis and he is a non-high risk patient, you investigate with ultrasound or CT with or without IV contrast. You start with ultrasound, and if there is still doubt, you use CT. In high-risk patients, situation differs. High-risk patients, children, women, childbearing period, elderly, immunocompromised. In children, we use ultrasonography. CT is the second option. Women in childbearing period, we use ultrasound. Here, you don't use the CT, you use MRI. In elderly, immunocompromised patients, you go for CT as the first option. The other situation is the patient who is presenting late with possible complicated appendicitis. In any patient, either he is a high risk or non-high risk patient, this is a delayed presentation. You find high fever, more than 38, palpable mass, toxic look, and signs of systemic inflammatory reaction. Prompt evaluation with ultrasound and or CT diagnosis are mandatory to evaluate the condition, whether pus is present or not, or it is only a phlegmon. Surgery through a midline exploration is a must if pus is present, while Ochsner technique is advised if no pus is present, with interval appendectomy done after 3 months. Appendicitis imaging recommendations. No imaging in typical presentation in non-high-risk patients. Sonography in children. In young women, CT can still be indicated. I said if there is a pregnancy, you use MRI, not CT. CT in the elderly, in the obese patients, if symptoms are more than 2 to 3 days old. Differential diagnosis. The diagnosis of acute appendicitis is essentially clinical, and the rest on the finding of pain, tenderness, guarding in the right iliac fossa with roving sign and rebound tenderness. Differential diagnosis, ureteric colic comes as number 1, gastroenteritis, intestinal obstruction, acute mesenteric adenitis, intussusception, and Crohn's disease are gastrointestinal differential diagnosis. Acute salpingitis, rupture ectopic pregnancy, twisted ovarian cyst are gynecological problems. Perforated peptic ulcer, acute pancreatitis are from the upper part of the abdomen. Meckel's diverticulum and Henoch-Schlein purpura are especially in children. Now, treatment. Appendectomy is a standard for care. Patients should be NPO, given IV fluid, and preoperative antibiotics. Antibiotics are most effective when given preoperatively, and they decrease postoperative infection and abscess formation. So appendectomy is the golden standard for treatment of acute appendicitis. And when I say acute appendicitis, this means that not more than 72 hours passed from starting the pain in the right iliac fossa, or even the pain that was felt in the epigastrium or periumbilical region. Immediate operative treatment is indicated in these patients, especially in non-high-risk patients. In case of a perforated appendix with phlegmon formation, if it is only a phlegmon formation, inflammation without pus formation, you can do what we call interval appendectomy, and this is usually performed with drains left and skin subcutaneous tissue open for weeks. This means that the patient with phlegma, you can treat with a conservative osseous nerve technique until the inflammation subsides, and then you wait for almost 3 months and you do interval appendectomy. Perioperative antibiotics have been shown to lower the infectious complications. Treatment of acute appendicitis is appendectomy. Now we talk about the conservative treatment, osseous nerve sharing technique. This is only indicated if there is no pus as evidenced by preoperative CT. If it is only inflamed mass around the appendix with no perforation, with no pus formation, you can use this conservative treatment. It is the backbone of this treatment, of this method of treatment, is to use nail by mouth, NBO, and to use antibiotics properly chosen with IV fluids. This is the backbone of this method of treatment. This method is contraindicated in the following conditions. Children below 10 years, because the possibility of free perforation with free peritonitis. In elderly patients, because they cannot tolerate long time treatment, especially in elderly patients. There is usually a comorbidity of diabetes, hypertension, diverticular disease, chest problems, and so on. In diabetic patients, don't wait, don't use this technique. And if you are still doubtful in diagnosis, this conservative treatment again is used for sure diagnosis of phlegmons without perforation, without pus formation in a non-high-risk patient. And then after 3 months, you do an interval appendectomy. Conservative treatment, this strategy is based on the principle that inflammatory process is already localized and the inadvertent surgery is difficult and may be dangerous. Because if you try to dissect tissues inflamed, you can perforate them. So it's better to wait, provided there is no perforation again and there is no pus. It may be possible to find the appendix, and occasionally a fecal fistula may form. For these reasons, it is wise to observe a non-operative program, but to be prepared to operate should clinical deterioration occurs. So the second cause of using this conservative treatment, the first cause is the difficulty of trying to dissect through inflamed tissues. Second cause, that you may not be able to find the appendix, and sometimes because of minor perforation or something like that, you can cause a fecal fistula. That's why we go to non-operative program, but be ready to operate once the clinical case started to deteriorate. This means putting the patient in semi-sitting Fowler position, IV fluids, NPO, nothing by mouth means, antibiotics proper and full dosage. Follow-up of the following. You follow up the temperature, the pulse, the pain, and the mass size. If these are improving, you continue. You give them a chance of 3 days. Improving, you continue and start oral treatment. If after 3 days there is deterioration or the condition is not improving, you have to interfere surgically. This is done for 3 to 5 days until patient starts to tolerate oral fluid and mass starts to disappear. Continuation of the antibiotics is done until fever and pain disappears and the appetite is regained. This happy end cannot be achieved with the presence of pus inside the abdomen. It happens when the mass is only a phlegmon. Interval appendectomy after 3 months is advised to avoid recurrence of the case. This is acute appendicitis, and this is the target we are seeking. Ligation of the artery, appendicular artery in the mesoappendix, away from the other suture that ligate the appendicular stump. This appendicular stump can be left like that or can be embedded inside the cecal wall by using what we call a purse string suture. This is a controversial part that surgeons are different. What I advise you is to use a purse string suture if the tissues of the cecum are good, not inflamed, and the situation is possible for using the purse string. This means that you are not passing a long time for dissection, possibly manipulating too much the tissues. And if the case is like this, you can leave the stump like that. Now, laparoscopic appendectomy is advised in some cases. And this is the target of laparoscopic appendectomy. This is an inflamed appendix with the inflamed mesoappendix. The target is to separate here the mesoappendix from the appendix and put clips to occlude the appendicular artery at the termination of the mesoappendix, and then you put clips at the stump of the appendix. No purse string sutures are used in laparoscopic appendectomy. Postoperative complications, bleeding, and these usually from the appendicular stump if not ligated well or not identified. Urinary retention, that's why we usually advise to use a catheter until you finish the operation. Wound infection, this is a very common complication, and usually the infection comes in the subcutaneous part, not deep in the abdomen, which is a good outcome. If the infection is deep, it can perforate any structure, but usually the infection is subcutaneous, and it is treated by just opening some of the sutures of the skin wound, leaving to the subcutaneous infection to drain, and taking a culture and sensitivity for the antibiotics to be selected properly. Intraperitoneal abscess, this is a catastrophic postoperative complication, and it should not happen, especially if you use a CT properly before diagnosis, because the CT indicates the presence of the abscess cavity, which should be drained. If it occurs intraperitoneal abscess, the patient will deteriorate in spite of removing his appendix, and here again we are talking about an acute abdomen condition where the CT can be used again to localize this abscess, and then this abscess either it is drained surgically or drained by ultrasound guided drainage, inserting what we call a small catheter we call pigtail catheter. Post-appendectomy fistula, this is an unfortunate postoperative complication, and this fistula is a fecal fistula. it's usually coming from the appendicular stump or as minor perforation in the cecum or in the terminal ileum during manipulation, pouring stools from the skin, and a CT here is mandatory again to be used. If there is no collection inside and this fistula is low output, is not pouring too much of the intestinal contents, you can wait until it closes spontaneously, or otherwise you have to interfere surgically. At last, intestinal obstruction. Intestinal obstruction is a very common complication after post-operative period follow-up after appendectomy because of adhesions. Usually the adhesions come through the appendicular stump, or sometimes the adhesions occurs at the bed of the appendix, and this means unfortunate outcome to the patient, but you can treat it conservatively, or you can reopen the abdomen to do what we call adhesolysis. This concludes our lecture, but we are going to re-summarize the condition, the lecture, into putting the patients in these positions. And abdominal pain patients can be put into 4 groups. Group 1, classic presentation for acute appendicitis, and this in non-high-risk patients prompted surgical intervention. Group 2, suspicious but not diagnosed acute appendicitis, benefit from imaging and from re-examination after 4 to 6 hours in the ward, with surgical consultation if serial examination changes or imaging studies confirm. Patients are given instructions to return if you are going to, if the clinical examination revealing resolution of the symptoms, you are going to discharge the patient, but you instruct him to come next day for another examination to make sure that everything is okay. We also advise to avoid strong analgesia in order not to mask the situation, not to mask the clinical manifestations. Group 3, high-risk populations, including elderly patients, pediatric, pregnant women, or immunocompromised patients require high index of suspicion, low threshold for imaging. That means that you image as soon as possible, and surgical consultation and surgical intervention. Group 4, patients presenting with complicated appendix, delayed presentation. This means that 72 hours or more has passed. You will find high fever, palpable mass, toxic look, and signs of SIR. Here, prompt evaluation with CT for diagnosis, and here surgery is mandatory, except in very few cases where there is no pus and there is only a phlegmon present. With a non-high-risk patient, you can only, this situation, resort to Ochsner technique for non-surgical management. Prognosis: the mortality of appendicitis is the mortality of delay. That's why, especially in high-risk patients, the 4 groups I have mentioned, that's why we advise usually urgent, prompt intervention if the patient is non-high risk and there is classical presentation, and this occurs in 50% of the patients. Most surgeons are therefore believe that a certain number of negative explorations are necessary to avoid a high incidence of perforation and its sequelae. Of course, this was an old statement. Now it is not accepted because of the presence of ultrasound and CT. Can negative laparotomy be lowered without a concomitant rise in perforated risk? The answer is yes, by using promptly ultrasound in an efficient with an efficient ultrasonographer and use of a CT with IV contrast. Thank you.